The removal of tonsils and adenoids is one of the most common surgeries in children. In a children's referral hospital like Gertrude's, this accounts for a significant number of the total surgeries that the facility does. Not all children with a problem with their tonsils have them removed, but for Joseph Ngugi, his daughter at 3 years of age was not doing so well with her tonsils, affecting even her social well-being. We joined Dr. Wahome Karanja, an ear, nose, throat, nasal and sinus surgeon at Gertrude's Muthaiga, as he performed this tonsillectomy. He explains the circumstances that lead to removal of tonsils and the procedure itself.
Tonsil surgery is actually the commonest surgery done, especially in the pediatric age group in children. And in combination with adenoid and tonsil surgery in this hospital and in many other pediatric hospitals accounts for much more than 50% of the total surgeries that are done. And that would, as an estimate, would be between 5 to 10 procedures in this particular hospital. So that makes up for a huge surgical load in terms of patients.
Well, Mama.
The doctor explained that they will remove the tonsils. It's a procedure that will take less than an hour, and within a couple of days she should be okay, and within 48 hours she should be able to eat normally and lead a normal life. Yeah, the doctor also explained that there are cases where there are complications, but those are rare cases. So, and with that advice, we thought it's good for her quality of life, as the doctor said. The complications could be bleeding, maybe a reaction to medication that is used in theatre, but what the doctors have been saying is those are rare cases, and this is a procedure that Gertrude does all the time. Initially, we thought it was just a normal cold and she would get a fever, so we would take her to the doctor for examination. So what became a concern for us is the frequency. So every few months she would have to go back to the hospital, and every time we'd get antibiotics. The fever would go away, she'll be well for a while. Then eventually, maybe 2 months or 3 months later, we still have to go back to hospital to repeat the same process.
She's a 3-year-old child about to undergo pediatric or tonsillectomy. So the anesthetist is holding a mask to her face and inducing anesthesia. These are inhaled medications that assist the child to be able to go to sleep, after which he can be able to put in an intravenous needle access, which will be able to give medications that will allow her to undergo the process of anesthesia.
There are days when, especially when it's very cold, like now, she would wake up maybe 3 or 4 times a night. And she will wake up and probably she'll go back to sleep. If she doesn't, she'll completely wake up. And if she wakes up, everybody has to wake up. So she'll start walking around the house, calling mommy and daddy.
So once you are sure that we're dealing with the right patient and we have given anesthesia correctly, then we're able to begin the process of surgery. Globally, adenoid and tonsil surgeries form a large part of pediatric surgery. In fact, it is the commonest surgery done in children. And so for a hospital like Gertrude's Children's Hospital, it is certainly the commonest procedure that is done, and it composes at least well over 50% of total number of surgical procedures in all their 3 operating theaters.
The days she has not slept, she's very grumpy even in the morning, which means her whole day in school is not good. And sometimes the teacher will complain she's not concentrating because she hasn't slept. So we try to make her sleep earlier so that her days, even if she wakes up in the night, she has at least had some sleep. There are days also we have to pull her out of school for a couple of days for her to take medication. So with that, we find that also interrupts her education.
This child is actually asleep and therefore will not feel the prick or the pain of insertion of a needle, which of course improves the patient experience.
She's very playful naturally. On a normal day, she'll want to play the whole day. But on a day when she's not well, she'll not want to play with other kids. She'll find any reason to cry. She'll cry over everything. So that is not, for us, we don't find that really good for her social skills. She was having a lot of difficulty in eating. So there are some foods she would not eat. She would prefer soft food. And for a long time, she would actually prefer drinking milk, juice, anything that is hard, she would not agree to it because of the pain on her throat. So with those problems, we realize that it's not adding any value to her life. Just continue to keep, because initially we were very reluctant to have them removed. But as time went by, we realized we are spending more time in hospital, and every time she has medication, you come to the house, there are always like 3 or 4 different types of medicine that she has to take.
Ordinarily, this procedure would take about half an hour, so between 30 and 45 minutes, between start of the surgery itself and completion.
The anesthesia is a cocktail of drugs that we give to patients depending on their condition and what surgery needs to be done. The whole idea is to make them asleep, non-responsive to pain, to facilitate surgery, which others would be quite painful. And more importantly, we always have monitors that ensure that everything we're doing, we can see the effect immediately.
Would ensure her room is dust-free because of, if we eliminated the dust or improved on the environment, make sure the room is aired during the day and her beddings are clean all the time, we thought that problem eventually would just go by itself. We did not, other than the normal medicine from registered doctors, we did not try any other medication or alternative treatments.
The pediatric parameters are very different from the adult. They have smaller spaces to work with. The intubation tubes, for example, are much narrower than in the adult, and therefore the narrower the radius of that equipment, the less likely you are to deliver oxygen if you use the wrong choice of tube. If you give the wrong dose of medications, you can have harmful side effects very quickly. If you dislodge a tube during the process of surgery, because of not being gentle during that process, then you have those risks. If you have bleeding from a small child, 10 mLs from a small child is equivalent to a much bigger volume in an adult. So they decompensate much faster than in adults. And having said that, we do have relevant anesthesia training. We have consultant anesthetists located here and in a lot of the other government facilities who are locally trained to be able to manage pediatric anesthesia properly and successfully. We also have ENT surgeons placed again across the country in both government and private facilities who are able to deliver quality and safe care to these children who deserve that care.
She's young, and as a parent, you don't want your child to go through surgery. Of course, there are risks, and even when the doctors take time to explain to us how it's done, and it's not a life-threatening procedure, but still, as a parent, you feel this is your child, so you don't want to take them through unnecessary processes. And sometimes you think it will go away as they grow older. As much as the complications are minor and occur in rare circumstances, and I would not want my child to be one of those rare circumstances. So until she's out and I can see her play and she's awake and well, then my anxiety will still remain until I'm able to hold my child and know that she's better.
These are steps where you actually want to make sure that this tube goes into the right place. There's a high chance of it going in the wrong place, so it's quite critical and comes with some advanced training and experience. Oh, it's in the throat. We actually have two main pipes. There's one which is the food pipe, and there's the other one important for us, which is the pipe that goes to the lungs, which is able to deliver oxygen and gases. The tool we use has a light and enables me to see that I'm putting the tube in the right place.
I'm looking forward for a better quality of life, seeing her being able to have a good night's sleep with no snoring and being able to feed well. She's actually a very picky eater because of the problems with her tonsils. For the last 2 years, we've been visiting hospitals for her checkup, and doctors have been giving her mainly antibiotics and other care that is necessary to keep her going. But as time went by, it became so problematic for her because she couldn't sleep well at night. She's snoring, she has a problem breathing. Sometimes she has to wake up several times at night because her breathing is interrupted. So for the last 2 years, that has been the process. But eventually the doctor recommended that the best remedy for her was to remove the tonsils.
The uvula, or what we talk in our vernacular or Kiswahili, is the kilimi, and we can actually identify somebody from where they come from if they say kilimi kilikatwa, depending on the ethnic group and where they come from. So these are typically practices that have been carried on from generation to generation from different communities, and we leave it as a myth. The uvula has actually very little bearing on the incidence of tonsillitis, on choking episodes, the inability to feed or to swallow properly. Unfortunately, we have a lot of traditional attendants who cut off the uvulas of children, sometimes with very harmful effects, which include excessive bleeding that can appear in hospital as a medical emergency. So we encourage the public, the general public, that one, the uvula needs not to be removed except in very few cases or circumstances, and if you must seek advice, please get it from a qualified medical person who will be able to give you the right advice.
The next step is you wait for the surgeon to get ready and perform the operation.
These are important lymph tissues that help in fighting infections, where you have a lot of white blood cells that are located within them that help in a child's initial immunity early on in life, up to perhaps 2 to 3 years of age. And that is the reason why they are also the commonest site of inflammation or effect in terms of recurrent infections that usually manifest in terms of pain, fever, and actually time spent away from school in many school-going children. The whole process of dripping is not accidental, it's very deliberate, again to ensure that we do not contaminate or cause any infections. So try my drip kind. And this is called a bipolar cautery that helps to burn at its tip and therefore cause bloodless surgery. We also have suctioning equipment that is able to remove secretions. These are basically saliva from the mouth, and that allows your visibility. I have a headlight also that allows me to optimize the light into the area where we are operating. Tonsillectomy, some patients will ask you, are we going to cut anywhere? Yes, we will, but not external, because we operate into the mouth. And to be able to operate into the mouth optimally we require a mouth gag, which is what I have here, that optimally opens out the mouth and retains that open position to allow visibility and completion of the surgery. So tonsillitis usually occurs from infection, and that infection is either likely to be viral or bacterial. Viral, of course, the risk factor being school-going children, because they are in communication with one another, especially in early childhood learning, where you have a child who has a flu that passes it on to another child. Tonsillitis is also highly contagious, whether it is bacterial or viral in origin, and the symptoms mainly present in more or less the same way, meaning a child will complain about headache, maybe will be vomiting, refusing to eat, may have swellings on the neck, and also is really largely unwell. And on examination, you would see that they have a tonsillitis. Adenoids are not a problem, so I'll not even do an adenoidectomy. Okay, I'm in the bipod. So in terms of surgery, the way I do tonsillectomy, there are different ways. There's called instruments, and there's use of cauterized instruments. I opt to use cauterization with the dissector. So usually you just delineate the tonsil capsule like that. So you see how it sort of bulges out, and I hold the tip, and then that way I'll be able to follow the capsule all the way from the superior pole or the top pole to the inferior pole by carefully cauterizing as I go along. That helps me to achieve a very sort of clean operative field, and at the same time to efficiently remove the tonsil without a lot of collateral damage. In other words, injuring structures that ought not to be injured. Infection around the throat area is a spectrum of sometimes upper respiratory infection, so you may have a coexisting cough, or it can get complicated. If you have a tonsillitis, then certainly you are unable to eat properly, and in children they can quickly lose fluid, which means dehydration, and therefore you want to be sure that they have a very minimum period of no fluid intake, so you want to treat them as early as possible. The other thing is fevers. If they are very high and they tend to be in tonsillitis, you also have other risks of complications like convulsions, which can have detrimental effects in terms of brain damage, for example. There is a particular bacteria called Streptococcus, which can cause what is called strep throat or strep tonsillitis. And this bacteria is dangerous in the sense that it can lead to other complications which are potentially harmful, like rheumatic fever and rheumatic heart disease, which can actually damage the heart or even damage the kidneys of children. So every episode of tonsillitis, if it is related to strep throat, is dangerous, and therefore in children who have recurrent infections, they have more likelihood of developing these complications. So we worry a lot about children who get frequent and severe bouts of tonsillitis. You can walk very fast this way. As a country, we are very fortunate that we have the requisite skills for a lot of surgeries, not just in ENT, but in the entire field of medicine, to deliver quality care. As you can see also in the anesthesia department, again, there is really no difference between the equipment we use either here or in many other hospitals in the country, and in terms of the skills and experience of the anesthesiologist.
At what point do you advise a parent that we should remove these tonsils?
We have our own parameters as the Kenya Ear, Nose and Throat Society, and a lot of times we adopt what the American Academy or the British Academy actually adopts. And in terms of this, we usually say 6 or more episodes of tonsillitis in a year, or 5 or more episodes of tonsillitis in two consecutive years, or 3 or more episodes of tonsillitis in 3 consecutive years. And by definition, tonsillitis is pain on swallowing, fever, general ill health, which is confirmed by a clinical person to be an active tonsillitis. When you have these incidents of tonsillitis, we have found that you are more at risk of developing complications like rheumatic fever. You are also spending a lot of time from school. As a parent, you're also spending a lot of time from work to care for these children, and therefore the resources that go into the care of these children are a lot. Again, medicines are good, but medicines are also poison. And these are children who will tend to overuse antibiotics. And this has been pegged towards development of antibiotic resistance, which is something that we are really careful about currently. In this era of increase in pollution, rural-urban migration, and a lot of dietary changes, those are probably the factors that are responsible for a greater increase in the cases of adenoid disease or tonsil disease that we are experiencing. Having said that, it's very difficult. It's like tossing a coin and saying who you predict would have less bouts of tonsillitis going forward. So generally, as a rule, if you reach that cutoff of 7 episodes in a year, our advice is basically to remove. But there are incidents of people who tell you, you know what, growing up I used to have these bouts, and my mother told me after the age of 6 I stopped having those bouts. The peak age of these problems tends to be between 4 and 5 years of age for adenoid disease, and about 3 to 8 years of age for tonsil diseases.
It's been 20 minutes since the procedure started, and now it's over. Both tonsils are out. This procedure, removal of tonsils and adenoids, is one of the commonest surgical procedures amongst children, especially in a hospital setting like this, which is primarily a children's referral facility.
So we did an intraoperative timeout, and we do a postoperative timeout, which includes confirming that the procedure that we were supposed to do has been carried out, and of course confirming that the number of gauzes which you can see in front of you is correct and corresponds to the number that had been counted before. This minimizes complications like leaving of gauzes within body tissues, either in the throat or any other places of surgery. So a teamwork approach is really key in terms of safe and efficient surgery, and of course guaranteeing that a patient will recover properly after the operation is done. First of all, the technological advances are broad-based, and they cover both the surgical aspect and the anesthesia aspect. The use of certain tools like timeouts, which ensure safety and confirmation of the patient, are things that are important. In terms of technology, we used to use older anesthesiology machines that did not have a lot of parameters that recorded what is going on with the patient. Today, as you have seen, we have instruments that record literally every other parameter that ensures the well-being of a patient before, during, and even after surgery as they go into recovery. In terms of the surgical procedure itself, we have tools. Initially, we used to use what are called cold instruments. Today, we have other powered instruments that deliver electric current that burns at the ends of this current. In other words, what is called cautery. That means you preempt. So you have a feeding blood vessel, for example, to the tonsil. You can see the blood vessel. You clip it before you cut. And that allows you to have a very clear and dry tonsil bed or surgical field. And also, in end result being, you have faster operation, you have better operating time, less complications in terms of post-operative pain, and certainly safer surgery. As a surgical team, we all remain by the patient to ensure that everything will be fine and that they will be able to wake up properly into recovery.
So this is a critical stage. So many things can happen at this particular point. So meticulous steps have to be taken to make sure that our patient is well after the operation. So we have switched off what we call the anesthetic gases, the gases which help to keep her in the unconscious state, and slowly over time they just wear off from the body. With another cocktail of other medications, we try and we give her medication to try and regain back her muscle strength so she's able to breathe for herself, and again ensure she also has enough pain medication so that she's not in pain she wakes up from surgery. So it's a combination of several things that have to go on right for her to be okay. So it's a process that takes about 10-15 minutes, and this is the intensive phase, and there's another phase in the recovery area where she gets intensive observation and continues to get some supplemental oxygen.
A lot of times you have to have patient engagement or a parent engagement in this case being the child. We prescribe a lot of open communication with parents. We encourage them to do their research either through Google and see the parameters with which we use to make a decision. For example, how many times is this child actually getting a tonsillitis episode, and how is it affecting your family in terms of the time the child being away from school. Based on the evidence that you give them and what they discover, then we would encourage a joint approach to the decision for surgery. And I think once you use that, then you'll have less and less of public concerns in terms of over prescription of procedures.
The anxiety that had gripped Joseph and his wife was quickly replaced by a sigh of relief as they saw their daughter out of the surgery. The culprit that had threatened to hold their child hostage was firmly shut in the container, signifying a new era for them and their 3-year-old baby girl.
Yeah, I wanted to write that.
At this point, this may look like it was just any other surgical procedure, as if it was a simple removal of tonsils. But to this 3-year-old, what this means is that she will be able to have a good night's sleep, be able to play with other children, be able to eat, grow, and develop like children of her age group. That has been Health Digest. I'm Dr. Mercy Korir.